Hi, I'm Melinda Tascetta-Mullane, Editorial Director of Imaging Technology News, and we are here today at NCoBC 2016 in Vegas with Dr. Ernie Bodai, who is Vice President of the National Consortium of Breast Centers. Welcome, Dr. Bodai. Thank you for being here.
Oh, thank you for having me. It's a pleasure.
And today, Dr. Bodai is going to be speaking with us on breast density. So, Dr. Bodai, there's a lot going on recently with breast density. There's a lot more awareness. What can you tell us about the numbers and where is this heading?
Yeah, it's actually a good thing and a bad thing. And let me just put it in perspective. You know, today in the United States, we're doing almost 40 million mammograms per year. And breast density has been identified to exist in probably 50% of women. There's the classification of breast densities that go from A, B, C, D. There are 1, 2, and 3, and 4. And clearly 50% of the women fall into the BI-RADS 3 or 4 classification. And what has happened is, since 2009, with the original legislation that was introduced in Connecticut, about 24, 25 other states have also come up with a mandate that women who receive a report about their mammogram, that breast density should be included in that. And I think that's great. The problem is that it often prompts further testing and further evaluations, which then increase a woman's anxiety, leads to a lot of false positive recalls, and also to a significant number of biopsies that are done that turn out to be negative. So, you know, we've got sort of a conflicting situation going on here because, as many people are aware, the American Cancer Society, the United States Preventive Task Force has come out with recommendations that are actually saying let's decrease the amount of screening that we're doing, and now we're coming out with an opposite message saying let's increase the aggressiveness of the interventions for early detection. So the public is getting a mixed message. And not only the public, but unfortunately, so are the physicians. And, you know, many of the primary care physicians who are involved in breast cancer care don't really know how to interpret the information that they're getting from these cards. So, you know, they're so pressed to discuss other issues with ladies that they often are misread and they start ordering tests indiscriminately without actually discussing the implications of breast density in women.
So how does technology play a role in this?
Well, the advancement in technology, you know, since we've become developing a focus on breast density as a potential risk factor for increasing the chance of getting breast cancer, some people feel that actually it's not a risk factor as much as the fact that dense breasts obviously hide smaller cancers and therefore make them harder to detect. So it's actually a detection issue as opposed to an actual risk factor. But the general number that is thrown out there is that a woman with say a normal breast density over a 5-year period has about a 0.7% chance of developing breast cancer. And if you have extremely dense breasts, that probably doubles. But to put that in perspective for the viewers, it's also important to note that once a patient has a relative who's a first-degree relative who's diagnosed with breast cancer, their risk also doubles. So it's pretty much equal.
Now, there's been a lot of talk about BI-RADS scores. Can you address that a little bit?
Yes, of course. The BI-RADS scores were originally made up for mammography, of course, and they went through 0 through 6, 0 being indeterminate, 6 being known malignancy. And now the BI-RADS scores have been altered to include breast density, and they go from 1 through 4, or A, B, C, and D. 3 and 4, C and D, as they're called, represent the heterogeneity of density, and then 4 is greater than 50% of the breast being dense. But here's the problem with the interpretation of those scores is that currently they're very subjective, because you can get one radiologist that might give you a 2, another one might give you a 3. In addition to that, you know, ladies' density varies depending on where they are in their menstrual cycles, depending on a number of factors. So one year there might be a 2, and next year there might be a 3. So what's happened is several companies have developed technologies which now standardize and objectively measure the amount of dense tissue compared to the fatty tissue in the breast. So it removes the subjective evaluation from the radiologist and makes it using a very complicated computer algorithm, gives them an exact score of what the density truly is and what number or letter it should be given.
And Doctor, on the legislative front, where is all this heading?
Well, that's a great question, and I'm a big advocate. I've been responsible for not a lot, but some legislation related to breast cancer issues in particular, and I have mixed feelings about this because, on the one hand, I think it's great to legislate and advocate for instance, things such as increasing cancer research dollars, increasing research facilities, etc. On the other hand, I get a little bit concerned when lawmakers start dictating to practitioners how they should practice. And you've got a bunch of legislators sitting in their offices who've never even seen a mammogram, and they start advocating or proposing legislation to address how a physician needs to discuss that, what to do with that data, and frankly, there's very little data to show that increasing the use of ultrasound or tomosynthesis in a dense breast is going to make any difference in long-term mortality, and that's where we're kind of stuck. Now, there is a federal piece of legislation that's pending as well that's been introduced in the Senate, and it is moving along very slowly.
Wonderful. And where do you, can you tell us more about that legislation? Where is it? What's the ultimate?
Well, right now, the version I'm aware of is in the Senate. There's also a counterpart in the House, and basically that legislation is meant to mandate that radiologists inform women that they have dense breasts and also educate them about what it means that they have dense breasts, and to recommend supplemental screenings as indicated. The problem is that nobody really knows where to go with that information.
Right.
And in the assessment tools that we have, breast density may or may not be a risk factor, but there's many other risk factors like family history, age, previous history of ovarian cancer, for instance, the BRCA mutation, and the models that are used for risk assessment today, not one of those, the most famous one is the Gale model, not one of those addresses breast density at all. So that's a huge, huge gap that we have to fill. I think the take-home message is that there are new technologies that are available that are increasing the accuracy of early detection. There have been a few studies done that have shown that adding ultrasound or tomosynthesis to a screening mammogram may find an additional 3 to 3.4 or so cancers per 1,000 women. So, things are on the horizon that are going to resolve the issues of who really needs to be screened further and with what technologies. And then some of the interesting things that are coming out are new contrast agents that are being developed, particularly at the University of Michigan, that are going to be labeled with agents that actually attach to breast cancer cells and blood vessels. And these imaging agents will provide an extra form of contrast so that we might be able to see smaller cancers in denser breasts. And so some of this stuff, hopefully in the next 3 to 5 years, will resolve itself.
So if people would like more information, do you have recommendations on where they could go?
There's an excellent website called Are You Dense, which has a tremendous amount of good information, and it started by the lady who originally was responsible for the legislation in Connecticut.
Thank you very much, Doctor. I appreciate it.
You're so welcome.